Hello, everyone, and welcome to the Fairbanks Ethics Lecture Series. I'm Alexia Torkey. I direct the fellowship at the Fairbanks Center. This lecture is being recorded and broadcast today, so thanks to those of you joining from IU Health Arnett, Ball, West, and IU Health Blackford. Please silence your pagers and electronic devices, and if you need to return a phone call, we ask that you step out of the auditorium to do so. I wanted to put in one brief reminder for those of you interested in our Ethics Fellowship. The applications are due April 30th, and there are flyers out on the table if you're interested in that. It is my pleasure to introduce our two presenters today, Shelley Johns and Kathleen Beck-Coon. Shelley is a board-certified clinical health psychologist who's been caring for adults with cancer and their families since 1996. She joined the faculty of IU School of Medicine in 2012 as an assistant professor in general medicine and geriatrics, and she has a clinical practice within the Palliative Care program at Eskenazi Health. I could list her many accomplishments, but she has actually asked that I be brief so that they have time for their entire presentation. And so I could go on for a long time, actually, but I won't. Dr. Kathleen Beck-Coon is a retired obstetrician gynecologist and 1978 graduate of the IU School of Medicine. She has had extensive training at the Center for Mindfulness at the University of Massachusetts Medical Center and has been teaching mindfulness-based stress reduction at Indianapolis Hospital for more than a decade. So it's my pleasure to introduce Dr. Beck-Coon and Dr. Johns, and I'm sure you'll enjoy what they have to say in the next hour.
Hello, and thank you for spending your lunch hour with us today. Today, Kathy and I will be telling you about a recent pilot study that we conducted where we tested a mindfulness-based intervention for adults with advanced stage cancer, their family caregivers, and their oncology providers. And many people, when we proposed this study, looked at us incredulously, shaking their heads saying, ain't no way you're going to be able to do this study. It's not feasible. We don't think this is going to be feasible. But we're here to present some evidence, and then you can decide for yourself if the study was feasible or not. Hang on just a second. I went too fast. So the reason why we decided to conduct this study is because of the statistics that show that the majority of patients who die of an advanced stage of cancer do so without having had a timely end-of-life discussion prior to the final month of life. This is inconsistent with clinical practice guidelines that state that these conversations ideally should be happening shortly after the diagnosis with an advanced stage of cancer. And it's understandable why that would be. These are very difficult conversations to have, and they are best had before patients become terribly ill. And so if we can back these conversations up earlier, it gives people the time that they might need to really process the medical realities of their lives, the meaning of these realities, so that wise decisions consistent with people's core values can be made. As I said, most of these conversations are not happening early enough. And part of the reason is because patients wait for their oncologist to bring these topics up. Many patients also say that they prefer that their oncologist speak truthfully with them about their prognosis and their treatment options, but they're still waiting for the doctors to bring it up. And that would be fine, except that a recent study suggested that 60% of medical oncologists are not bringing these issues up until there are no more treatments to give. And most people in this room know that when there are no more treatments to give, patients are usually quite ill and may not have the cognitive capacity at that point or the energy to be able to have these difficult conversations. Here are some of the factors that you can see for yourself, the reasons why some of these conversations are not happening in a timely fashion. A lot of it goes down to these are difficult conversations to have. This isn't just, hey, where do you want to go for dinner? These are conversations that are much more emotionally intense and just more tender. And so patients, family caregivers, and providers all, tend to avoid these conversations as long as possible. Also, our practice environment and our healthcare system is really not set up to be able to support having these conversations earlier. Clinics are overscheduled, doctors have too many issues to address in a brief medical appointment, and there's also a lack of reimbursement for having these conversations. A recent report that was released by the Institute of Medicine entitled Dying in America, improving quality and honoring individual preferences near the end of life, one of the key recommendations in this report, written by leaders in our field, is that we need to really change the policies and the payment systems in order to support these conversations. And so we agree with that. Also, 4 of the other recommendations in this report were things that we tried to address in our model care intervention that I'll tell you about. So we were pleased when this report came out, actually after our study was over, to see that what we offered was consistent with what leaders believe need to happen. So the bottom line is that there are fairly dire consequences when these conversations are not happening in a timely fashion. One of the biggest is that aggressive, non-beneficial treatments near death are happening when patients are not given the opportunity to really think about what their goals of care are and to make some of the decisions about that. And these aggressive treatments that are non-beneficial are expensive, and so that adds up to a great deal of financial burden on our healthcare system as well. Moreover, patients are deprived of the opportunity to receive the benefits of palliative care. And when, as we all know from the big report that was released in 2010 from Jennifer Tenmel in the New England Journal of Medicine, when palliative care is integrated with care earlier in the disease course with advanced stage cancer, the outcomes are much better in terms of quality of life, in terms of mood for the patients, and also life was extended by about 2 months when palliative care was integrated earlier. So these are some really good reasons why we all need to think about innovative solutions of how we can start having these conversations earlier. And so Kathy and I put our heads together, and we thought that a mindfulness-based intervention, not just for patients, but also for their family caregivers and for their oncology providers, would be a way to address some of that avoidance that oftentimes happens, oftentimes for emotional reasons. And we thought a mindfulness-based intervention would be very helpful. And so mindfulness is a human capacity that we all have. Everybody in this room has the capacity to be mindful. But it's something that can be improved or increased with greater practice. It's about present-centered awareness. It's about being in touch with what is happening in this moment in a non-judgmental and compassionate way, not just for ourselves, but for others in our midst as well. It's learning how to be with our thoughts, feelings, and sensations in an open and curious way, so that we can make decisions that are consistent with our values instead of just choosing, out of habit. So the name of our intervention was called Mindfully Optimizing Delivery of End-of-Life Care, and we shortened that to Model Care. And again, we enrolled all 3 parties who were involved in these conversations, individuals with advanced stage cancer who were not likely to survive more than a year, as well as their family caregiver and their oncologist or their oncology nurse. We offered a single-arm pilot study, so it was not randomized, because, again, we were told this is not going to be feasible. So we wanted to check to see if it was feasible before we did it in a more expensive randomized trial. We assessed a variety of outcomes that I'll show you in just a moment at the beginning of the study, at the end of the 6-week intervention period, and then 1 month later. And we also conducted qualitative interviews at the end of the intervention period, and we'll spend some time today telling you or sharing with you some of the quotes directly from the wise minds of our patients, family caregivers, and providers. Our primary aim, again, was to check feasibility, and we wanted to look at the feasibility of enrollment, attendance, retention, and also the satisfaction. Because just because something's feasible, if patients don't like it, it's not going to be something that we need to proceed with. So we wanted to see if it was satisfying to people. And we also wanted to look at preliminary effects on a variety of outcomes. And we had a lot of outcomes because, again, this was an exploratory study. The main thing that we wanted to look at was avoidant coping. But we also wanted to look at quality of life. We wanted to look at a variety of symptoms, depression, anxiety, sleep disturbance, and fatigue. And the reason why we wanted to make sure include the symptoms is because, Kathy and I had conducted 2 other trials with post-treatment cancer survivors who were disease-free, and all of these symptoms moved in a fairly big way, as a result of, the mindfulness-based intervention in randomized trials. And so we wanted to just see, would it help people with more advanced disease and their family caregivers? Would it help with some of these symptoms? We also wanted to assess mindfulness as a potential mechanism of benefit for the intervention. And then for just the patients, if you can look a little bit to the left on the lower quadrant of the slide, we also assessed advanced care planning behaviors, thinking that if people became less avoidant in their coping, they would be more likely to complete some of these important advanced care planning behaviors, such as completing a post form, which we know from the work of Dr. Susan Hickman here, stands for Physician Orders for Scope of Treatment. It's a key advanced care planning tool where patients can identify what kinds of treatments they want as death draws near. We also wanted to look at goals of care conversations with the patient's family members and also with the oncologist. Here were some of the measures that we assessed for our oncology providers, and we enrolled 4 oncologists from the IU Simon Cancer Center, and we also invited their nursing staff to participate as well. We only had one nurse who was able to commit the time to doing this, but it's because we did this nights and weekends for our busy oncology providers, and so it's no wonder that the uptake was not greater than it was, and we'll talk more about that in just a moment. But for oncology providers, we looked at coping, quality of life, symptoms, mindfulness, and also their advanced or their end-of-life care behaviors. And so for this measure, it was 5 different behaviors that included, talking about end of life, conducting advanced care planning discussions, and handling, difficult emotions. So those were like 3 of the 5 behaviors. And for each of the behaviors, we asked how important they thought that was to quality care, if they knew what to say when those, behaviors were addressed, and their confidence in doing each of those. Patients were eligible if they had an advanced stage solid malignancy, and their oncologist said that they wouldn't be surprised if the patient died within the next year. They also had to have a family member or a friend willing to participate, and they could not have already signed their post form, because again, if somebody has already signed their post form, they're probably not coping with a lot of avoidance. So those were the criteria for patients. Family members just had to have a family member, a patient, that they were caring for, who was enrolled in the study. And then oncology providers were eligible as long as they weren't going to be leaving the IU Simon Cancer Center in the next 6 months. And so now I'd like to turn it over to Kathy, who's going to talk a little bit more about the intervention and the ethics involved.
So no intervention or its measure really has a place without the ground of this lecture series, which is ethics. And I'd like to speak a little bit to that. It's certainly why we're in this room. It's why most of us are in this medical center. Personally, for me, it's why I'm in this work and certainly this study. And it's the source of our momentum as we develop. And here you'll see some of the principles of mindfulness surrounding the 4 classical ethics principles of autonomy, beneficence, non-maleficence, and justice. And it is this kindness and compassion of mindfulness, as we're compassionately paying attention moment to moment, that really encircles and supports these ethical principles, so that we can have an open, honest conversation that can benefit patients, their caregivers, right in this, so that this is the milieu right in the midst of the shakiness and uncertainty that is this place near the end of life in talking about end-of-life care. And I'd like to proffer that this open, honest, kind conversation really does not put at any odds the beneficence, the well-being, the best interests of the patient, the family caregivers, the oncologist. And by the way, when I say oncology or we talk about physicians, there were more physicians in this study, but I'm also talking about nurses. I'm a huge nursing advocate as a sidebar. So nursing specialists, nurse practitioners, so it includes all of us as caregivers. But we're in service of all these principles, and with what Shelley talked about from the IOM and the principles that we're looking at in this study and what we'd hope to do, I would proffer that we are really not putting anybody's beneficence or benefit at odds with one another, including that of society, when we bring the kindness and education that can set the table for these conversations. And it brings to mind a poem, or a statement actually, by the mindfulness teacher Pema Chodron, who says, "Compassion is not a relationship between the healer and the wounded. It is a relationship between equals." This recognition of our common humanity is actually a source of the justice factor in ethics. And when she says compassion becomes real when we recognize our shared humanity. This interconnectedness of our shared humanity is really, to me, more the ground of non-maleficence than any fear about doing harm. It's this recognition of connectivity that comes when we pay attention. So mindfulness meditation certainly supports these principles of ethics in interpersonal communication. And our own Paul Helft, who couldn't be here today, the director of the Charles Warren Fairbanks Center for Medical Ethics, was asked in a Medscape interview 3 weeks ago, and some of you may have seen this, about a survey that was done from 494 oncologists last fall. And the question that one of the questions had asked was about whether or not they lay out the risks and benefits of treatment, even if describing those risks might prevent a patient from pursuing a treatment. Certainly, this is a question that highlights non-maleficence. 75% said yes, they would. 11% said no. 14% said it depends. So that's 25% that did not say yes. And it was pointed out in Paul's discussion that even when fully describing risks and benefits, physicians, and again, physicians or nurses, may unconsciously frame the informed consent conversation in such a way that it may influence the patient's decision. And Paul said, we frame things in terms of how we read the situation. Exactly. How could we not? That is perspective, and our perspective comes from our personal and professional experience to this point. But it's good to recognize it as our perspective, because it is sometimes euphemistically called the art of medicine and not seen as perspective. So I think it's very helpful to notice that as much as is possible, we can bring in objective facts which are combined and include the very germane perspective of the people in front of us, our patients and their family caregivers, so that this dialogue can be supportive of the beneficence that is supporting patients and families in this adjustment in this difficult time of life. So the intervention in the model care course had two arms. The one, it was two-pronged, so this is the patient and family caregiver arm. It was also mutually interactive with the other arm in a common session near the end of the intervention. In both, we've opened up practices for the patients and their family caregivers. These were 2-hour weekly group sessions, and folks did not find this too long. We gave guided instruction in mindfulness meditation, which included the body scan, getting to know the body as it is, mindfulness meditation in sitting meditation, in movement with mindful, very gentle hatha yoga, and in a practice called loving kindness, which is just what it sounds like. This experiential practice was also supported with the didactic doorway of education around self-regulatory skills of stress reactivity supported by mindfulness, information on palliative care, and opportunities to consider very specific advanced care planning tools, including the post form, as Shelley mentioned, just as a way to honor and facilitate their individual choices. And these were further explored in the combination session. In the week before and during that session, we particularly opened up those processes. So for the oncology care provider arm, the same practices were opened up, and as well, we talked about triggers that can be a challenge in communication, and looked at contemplations around what is suffering for the care provider themselves and what is suffering in communication with patients and their families around these conversations, and what might we as care providers actually want for ourselves at this time of our life when we're needing this support. So meditations of the body scan, yoga, sitting meditation, loving kindness were in both groups. And we also introduced some reframing for the patients and their families and the caregivers about what is hopefulness at this time of life.
Okay, so now I'll tell you a little bit about some of the outcomes that we had in the trial. Here you can see the patient flow into the trial, and this is a lot of numbers on the slide, but the summary statistic would be that we enrolled 13 patient family caregiver dyads, and that was 19% of those who were approached, and it was also 59% of the eligible patients actually enrolled. So those numbers may sound, the 19% may sound a little low, but that's actually, pretty good with end of life care. And the 59% of those who were actually eligible enrolling really speaks to the fact that these patients and these family caregivers were really kind of hungry for something, to think that many people who were eligible actually enrolled. And just so you can see a little bit about the characteristics of our patients and our family caregivers, it was largely a Caucasian sample, college educated. The majority of the caregivers were spouses, but we also had 2 adult children, and we had 1 family friend. And in terms of feasibility, we wanted to look at the enrollment rates as well as retention and attendance, and you can see those numbers here. You can see that all the caregivers who were invited to participate did. So caregivers are really hungry for any help that they can get. The retention rates were remarkable for this patient population. We had 1 patient family caregiver dyad who dropped out after the first session, but everybody else who could continue to participate did. The attendance rates were fair, and these numbers, the 70-72%, that boils down to about 4 1/4 sessions out of the 6 for each of them. The biggest reason for not showing up, we had lots of people who were admitted to the hospital for a variety of reasons, people who were too ill to come a variety of times, and we also did this in the middle of the summer with all of the storms. I don't know if you remember, but we had a lot of big weather, and so we had a lot of storms last summer, so a couple people couldn't make it out in the rain. Here you can see the satisfaction outcomes. Patients and family caregivers, more than 90% reported being mostly to completely satisfied with model care, and the modal response was complete satisfaction. You can see also in terms of the mindfulness practice, Kathy handed out all of the formal practices on a CD, and so the formal practice rates are related to either using the CD for the longer formal practices or doing those same practices without the CD guidance. And so patients and family caregivers were practicing about 3.5 days a week in addition to the day of class, and so that's a nice amount of practice. We were pleased with that. And more remarkably, they were continuing to practice almost with as much frequency in the follow-up period, even when they didn't have the weekly support at the class. So this really suggests nice engagement, we think. And informal practices were happening a lot more often, almost 5 days a week across the whole period. And informal practices would be, like you and I having a mindful conversation, really attending to the conversation, or having a mindful ice cream cone, or watching a sunset mindfully. Those are considered more informal practices, but still vitally important in bringing the practice to bear on the entirety of our lives. We also asked, how likely are you to continue to use what you learned in the model care course? And more than 90% at both time points said that they were likely to extremely likely to continue. And again, you can see the modal response was being extremely likely. So we were pretty satisfied with their satisfaction. Here you can see, this is a lot of numbers, for one slide, but you can see the differences between patients and family caregivers. These are based on effect sizes, which for those of you who are not, fans of statistics, an effect size indicates the magnitude of the effect of an intervention that we've offered. So we all want large effects, right? We want our interventions to be highly impactful. And so what I've highlighted for you on the slide are any of the the effect sizes that are considered large and statistically significant. So you can see we had lots of nice movement from baseline to the end of the 1-month follow-up on reduced avoidant coping, increased acceptance of illness, and also nice improvement in quality of life. The reason why I'm just showing you the baseline to 1-month follow-up results is because the results were a little better from baseline to the end of the intervention, but the more rigorous test of any new intervention is, how much hang time does it have? And so that's why I'm showing you the less rigorous, but still pretty decent, results that were at the 1-month follow-up, which was a month beyond when they were having the weekly support. Also, the other outcomes we measured were symptoms and mindfulness, and you can see both patients and family caregivers, even at the 1-month follow-up, were still reporting large and significant improvements in depression, anxiety, and sleep disturbance. Not much of an effect on fatigue, though, and only patients were able to show significant increases in non-reactive coping with regard to their internal experience. Some of these other effect sizes that you see are moderate, but we're trying to only highlight the large ones here. In terms of the advanced care planning behaviors, you can see on the slide that there was nice improvement in all of the behaviors. The first on your left is the completing a post form with their medical oncologist. No one had done that at baseline because that was part of our eligibility criteria. By the end of the 1-month follow-up, 50% of our patients had done so, and 2 others had written on their form that they were planning to do that at their next appointment with their oncologist, but they hadn't gotten around to seeing them yet. Their appointment wasn't scheduled. So those are some pretty nice outcomes on signing the post form. And the reason why that's important is because patients are very clear on what kind of care that they want as death draws near. And these are in their medical record so that if they are rushed to the hospital for some reason and their oncologist is out of town, they have clearly specified in their medical record what kind of care that they want. So these are patients who are going to get exactly what they wanted. Also, about 40% of patients had a goals of care conversation with their family member before the study started, but all of them had done so by the time of the end of the study. In terms of having goals of care conversations with the oncologist, about 20% had done so at the time of the study, beginning of the study, and then more than 80% had by the end of the 1-month follow-up. And that, the goals of care with oncologist conversation, that was the only statistically significant improvement among these 3 advanced care planning behaviors. But the other 2, there was a trend, towards significance for both of those. And I think, the eyes have it on this one. You can kind of see for yourself the improvements. And so now the results for the providers were less robust for a variety of reasons. Again, I'd already said the enrollment rate was about 22% of those approached. Several other of our oncologists were interested in participating, but because of the timing of it, it was in June when people were going on vacation, and we were not enrolling people who knew that they were going to miss any of the sessions. And so that was why the enrollment rate was a little bit lower. Also, attendance was fair, 84% among our busy oncology providers. We lost one of them between the end of the intervention and the 1-month follow-up. Satisfaction was much less than with the patients and the family caregivers. The majority said that they were somewhat to mostly satisfied, and the modal response on that was somewhat satisfied. Some of the biggest challenges was just the commitment of time involved in this. So not only were we inviting them to do this nights and weekends, but then we were also asking them to practice on their own, between sessions, a half an hour a day or 20 minutes a day. And it was a lot to ask of our busy providers. And so they had suggested, is there any way that you could do this kind of in a one-day, event, or, just, like a couple hours. So, and that tells me that our oncology providers are just exceedingly busy. I mean, they are so busy trying to take care of patients that oftentimes having time for themselves is just not happening. And this may be one of the reasons why a recent national survey of the American Society of Clinical Oncology membership found that 45% of our medical oncology colleagues have clinically significant levels of burnout. And it's because they are so busy taking care of everyone else that sometimes their own needs get shortchanged. And that came out in our conversation with our providers as well. And you can see the practice. They were practicing the formal practices about 2 days a week in addition to the day of class during the intervention. Informally, they were practicing about 4 days a week at both time points. So that suggests that they did learn some things that were valuable, and they were continuing to practice that even informally beyond the end of the intervention. And the majority of them said that they were likely to continue to use some of what they had learned in the course. Since we only had 5 involved, we really couldn't look at their results statistically, but we did look, at the mean scores, and we did see some improvement, particularly from baseline to the end of the intervention, in their confidence in providing end-of-life care, as well as reduced secondary traumatic stress, reduced moral distress, and thanks to Lucia Woschel for inviting us to add that important measure to our study. Also, they had decreases in all of the symptoms that we assessed: depression, anxiety, sleep disturbance, and fatigue, and also improvements in mindfulness, particularly non-judgment of their internal experience. And so now Kathy's going to kind of lead us into some of the qualitative results of the study that she'll tell you about now.
For qualitative analysis, we used directed content analysis methods, so focusing on the significant quantitative findings. There were themes for a coding framework. 2 individual coders came together to discuss the definitions of these quantitative themes and then came to a consensus on creating this coding framework. Then as a guide, they read the interviews and recorded illustrative quotes to support this framework as they emerged. And what Shelley and I'd like to do is share a few of these quotes with you so that you can hear the real voice of all the people who were in the study. And we'll alternate these voices in their words. His stamina has slowed down. Maybe I was alarmed about it, but I guess I see how other members are also. I've processed that this is the way it's going to be, because he was such a gung-ho go-getter. He still is by all means, but it was such a shock to see him slow down. So I've learned to accept that. Yeah, I'm accepting the moment.
Essentially, I'm not thinking about perhaps where I'm going, but rather where I am.
I was in the process of going through radiation therapy, and when I would go in and lie on the table and they put this thing around my face, a mask, it's around my whole face, my head, all the way. It conforms to my face, and then they fasten it down on the table so I can't possibly move my head or anything. I felt I was trapped. I was trapped, and I know that. But by doing the body scan while we were getting me ready to have my treatment, well, that helped me a whole lot to get through those.
So when cancer happens, you're just like, there's nothing you can do, and you just have to let everybody take charge of your loved one and put all of this incident trust in strangers who may not even care for your loved one. And it's powerless. The mindfulness gives you some power back. It makes me feel more comfortable.
The other thing we talked about was the pause. I think that's good. When you're dealing with a stressful situation with someone you love, just because it's stressful, there are times when emotions get high, and it's always good to pause before you say something.
The pause that Kathy talked about allows you to not react in negative ways, but to think about, how can I better deal with the negative circumstance that comes up instead of dealing with it by a negative reaction.
And from one of our oncologists, it's rare that you can speak to someone without any judgment at all, and they reflect back to you and what you said without any judgment. And it means it's neither good nor bad, it's just what it is, and that's okay. We acknowledge that, and I found that to be the most effective thing.
I've got more pain lately, likely because of the cancer drug, So I'm practicing what Kathy taught us. I can usually stop trembling when I take a deep breath and let it go. Last week it was my shoulder, this week a hip. We'll see what the tests show next. I'm just still glad to wake up, though.
I probably benefited from it more, the mindful movement, because I'm the one that's shaking, and my disease centers on the lower half of my body and my legs with a lot of numbness and partial paralysis. Stretching those muscles allows me to walk better without pain.
And still sticking with the symptom theme, I was in bed sweating and shaking from fever, lots of pain too, and I could see my mind starting to race, wondering if this was going to be it. And then I remembered mindfulness. I let go and felt heat as heat, shaking as shaking, sheets as touch, thoughts just as thoughts. And suddenly it was all more tolerable. I didn't have to get rid of it, just be with it, and it felt better.
I think I've taken things a little bit calmer. I normally am a very driven person and anxious and want to get things done. But the method of pausing and listening, and this is one of the words that really caught my attention, and I'm treasuring the phrase, listening with intention. So when I'm at work, I really am listening with intention because I'm enjoying what I'm doing at that point. But once I'm out of the office, I am with him. I've had problems with anxiety my whole life, and this kind of stuff really helped calm myself down.
I've been handling my disease process very well, but when things happen that I've not expected, I think it made the symptoms much more severe because I would become anxious over them and then fear what was coming over my body. Like, oh my God, is this, have I grown a blood clot? Am I going to die? So I think mindfulness allowed me to take a deep breath, pause, refocus, and then move on. I really wasn't able to do that on my own before.
My wife left and went to California for 3 or 4 days this past week after the class ended. I was really lonely. I guess I got a little bit depressed, really. I don't like to use that word, but it's true. I was thinking, well, hell, maybe I ought to end it myself. I don't believe in that, and I wouldn't think I would do that. And then I realized I could use my tools of mindfulness. I would say that that's what I got out of it. It was a surprise because I realized I have this tool. I can use it. It will help me when the cancer gets me down. I can use the meditation and the yoga in a way that will help me. I can focus on something else other than thoughts of despair.
And we have just a few more for you. My favorite part of all was the body scan. I don't get down on the floor, but I could lie in my bed and relax myself. They taught us how to relax ourselves, and that really worked well for me. You get upset, uptight, you feel like your whole body is clenched, and then I lay down on my bed, and I can just relax a whole lot easier than I ever could before. It releases my mind from the trauma that it's in and just helps me to go a little farther.
And another quote from one of our providers. I feel like there is continuing demands on our time, 24 hours a day. Sound familiar? And we're doing multiple things all the same time. And if nothing else, it was a bit of relief to be able to focus and pause for a few moments to concentrate. I think this is allowing me to take a breath. It helps me not react quite so rapidly, and I think that's a good thing. You end up listening a bit more, reacting less, processing more.
And from one of our family caregivers, peace, balance, harmony, tools I can use every day to cope with the stress of cancer, family, and work. It's the serenity prayer in action, giving me power in things that used to make me feel powerless.
I think I know the reality. I know we can't change the outcome, so what's most important to me is that we enjoy every single day as it comes. So now I am living in the present, enjoying the present. I can think about the future, yes, but I'm not going to dwell on it too much.
My heightened awareness is helping him feel better. Even though it may not heal him physically, it can heal him emotionally. We now have a way to reach out to each other with a different set of eyes. It's part of the quality of life that he deserves. He's trying to open up to me a little more now that than he used to. So yeah, I've noticed a difference.
And in the shared experience that is this confidence, ease that comes in talking about the end-of-life experience and care. From one of our providers, I found myself talking to my patients a little bit differently about being kind to themselves, being good to themselves. My patients greatly benefited from participating, and I've noticed a huge difference in our interactions.
So there have been a lot of conversations, especially when talking about palliative care. I think it kind of reminds us both that we need to make a conscious effort to ensure the communication occurs on these important things.
Communication is 100% better because we would just ignore, not want to talk about it. I was always scared to talk to him about it because I thought that was going to be just the last thing to put him right over. And he's had a different reaction about it because of this course. I don't think it would have happened before. So it was really helpful.
I think some of the things presented have been things we hadn't thought about before the class, like doing those post forms. It's giving us the opportunity to have conversations, and we've talked more in depth.
And so after taking all of these generous words of our participants in that really voice what they touched, it might be nice for us to touch a little bit what was shared in this class as a practice. And that is for yourself right now to just come home to your own body as you know it's sitting here, eyes open or closed. Maybe even checking in tenderly with your own shoulders that might spontaneously release something you didn't even know you were holding. Knowing your entire body breathing in and breathing out just as it is. Relaxing and allowing.
So just to summarize for a few minutes before we open it up to questions, I think what we've all discovered with this intervention is that it is quite feasible and acceptable to patients and family caregivers. Kathy and I still need to go back to the drawing board a bit to decide how to proceed in opening this up to providers. And I also, would like to, appeal to, our wise and generous leaders here to think about, is there a way that we can invest resources, like they do at the Mayo Clinic or at Cleveland Clinic or at the University of Rochester, where we protect some time for our providers to be able to do some of these self-care practices that can not only help them to reduce, burnout and their own stress, but will also translate into improved quality of care to the patients that we serve. Mindfulness has been able to do that in other trials in other settings where they look at quality care in terms of quality of conversation with patients and other markers of quality care, and it seems to help. And so there might be a way that we could all partner together to try to see if this would be useful. I think we also showed that patients and family caregivers reported significant improvements, large improvements in important outcomes like quality of life, decreased depression, anxiety, and sleep disturbance, decreased avoidant coping. In other words, decreased suffering for some of the vulnerable folks, our friends and neighbors. And patients also made notable progress in advanced care planning, which means that they are going to be more likely to get the kind of care that they wanted as death draws near. And I would like to take just a moment to acknowledge, first of all, most importantly, a deep bow of gratitude to all the patients, the family caregivers, and the oncology providers who devoted their time to participating in this pilot study. Also, I want to thank the Walther Cancer Foundation for funding this work, to the Fairbanks Center for Medical Ethics for advising every decision that was made, including Paul Helft, Lexi Torkey, Lucia Woschel, even Steve Ivey, I think, weighed in on a couple of the decisions, and also to thank our entire team. So Kathy and I would like to open it up now to any questions that you all may have. And Amy Chamness has a microphone. I'm a little hearing impaired, so I'd like to kind of hear it on a microphone if possible. Thank you again for your attention.
This was completely amazing. I love your results. And basically every time you give a lecture, it's also a mindfulness intervention for us. So thank you for that. My question, I know that you had many effects, including on symptoms, but I'm curious about the advanced care planning effects. Although you had a small number of providers, I see you increased, for example, post forums and discussions with oncologists a great deal. And I do wonder if you could speculate on, for example, with post forms, it requires a physician's signature, and so you can't do it without an engaged oncologist. So I wonder, even though your numbers were small, how much of the post form completion and discussion with oncologists was because of activating your patients and caregivers, and how much was from activating your oncologists?
It's hard to know because, again, we didn't assess that, so it's hard to say. But I really think, and I will be interested to see what Kathy thinks. I think a big part of it was we opened minds on both sides of the table, and I think that's why it's really important to involve all three parties, in this. Because if we would have left any one of those important parties out, I don't know that we would have gotten these same results. I think the synergy happens when you have all three at the table. But there's no doubt our patients and family caregivers got really activated. So it's kind of hard to say.
And it is just what is stated in the literature. The patients want their oncology care provider to bring up the topic. I don't want to be a bad patient. You bring up when I need to talk about end-of-life care. The oncologists want the patients to bring it up because they don't want the patients to think that they're giving up on them. And both parties talked about this. And so what happens is nobody talks about it until, as Shelley said, somebody's in the hospital and they're too sick to really play the kind of part they would have liked to. Although when speaking to most of us in the room, that we lean towards less aggressive interventions and more connectedness in our care, nobody has a chance to talk about that. And I will say something that wasn't in the quotes after the study, but that was in the room, definitely. When we talked about palliative care and the post forms, there was actually some anger in the room because the patients and their families said, "Why has no one talked to us about this? We would have definitely taken advantage of palliative care. I want the power of this post form. Why has no one talked to us?" And again, it's the time factor, the avoidance, the difficulty in conversations, and this is a doorway.
Did you coordinate your care with the medical aspects, like with anti-anxiety meds and things like that? Was that a factor, or did you have the medical people withhold that to test this? Or I was just curious.
We really didn't. Because it was a pilot study, we really didn't even assess any of those things. So there's really no way to know, are all of the effects that you're seeing here, was it due to, people had, received a benzodiazepine, or was it because of what happened in the study? There's no way of knowing, but that's why I really like the power of the qualitative quotes, because from what we got out of those qualitative interviews, again, we were asking questions specifically about, what they got out of this. It really kind of looked like they were thinking that the non-reactivity that they learned in these practices really helped them to meet whatever arose in their lives with greater ease. And that's the reason when Kathy and I were having tea deciding, like, well, what should we do? We really wanted to try to reduce some of that emotional reactivity so that people could proceed with making the decisions that need to be made so that they could have these conversations. So but that's a great question. I wish that we could be able to answer that with greater, with more definitive. Yeah. What other questions do you have? There's one over here.
It's just kind of an idea that came up with that question was, it seems to me that the medications could act in correspondence with the mindfulness training, because if you look at people who are not necessarily medicated, and all the mindfulness information out there, I mean, there's a change. So if you can correlate that with what your information comes from, and also the differences of people who are medicated and not medicated that are not mindfulness people. But it seems like the two act together. So it would be interesting to see a mindfulness training with people that not necessarily, just looking at those two aspects on the correlation of the interaction of both interventions.
Although I also believe that sometimes our best practices can come when we're really, really stressed, and when maybe we don't have the medications on board, because then we can really see the difference between how stressed we were before a practice and then how much that lowers. As where if it's kind of moderated, with medications, you may not see kind of that improvement, and it may not be as memorable to you as it might be otherwise. But I think either way would be important to look at.
One of the profound consequences of cultivating this, as Shelley said, innate capacity for mindfulness that we all have and have touched in our lives, is that it's not about an end run around anxiety or challenge in internal processes or interpersonal processes. It's a way to engage and open to whatever's here, not just the shakiness, but the joy of the connectivity that is here in these processes. I'm sure all of you can recall very challenging conversations, or even being with someone in silence who has been suffering, and you were there, and they know you were there. And your to-do list for the next day and all the woulda, shoulda, couldas from the day before were not present. It was the just this of that mindful experience. And that's what's cultivated. It's not getting around the anxiety. It's meeting it head on and being with it in a different relationship.
Any other questions before we stop for today?
So this was very interesting to me, and I just wanted to know if you do grow your next study, do you have any goal to include other types of physicians? Because just from my minimal experience in the hospital, it seems that sometimes when they do get to that last year and they do have frequent hospital visits, there are other physicians that get on board with the oncologist. And even though the results for the oncologists weren't as strong, I feel that the more exposure to this mindfulness, it will enhance it. So I was just wondering what your plans were for growing the study. Were you just going to stick to the patients, caregivers, and strictly oncologists, or were you hoping to include other physicians?
I think that's a great suggestion, and I'm definitely open to doing that. Research happens, in a kind of a step-by-step form. And so the next plan is to take the pilot data that we have from the patients and the family caregivers and to proceed with that part of the study. And so we'll be submitting both an NIH and an American Cancer Society grant moving forward with that component. Because, again, the pilot data are pretty strong, and I think that we would have a shot of being funded to do that. We're also in communication with several other leaders on campus about how to move forward with the training for providers who are not just oncologists. So we've got to kind of figure out how we can move forward so that any physician on campus who's interested in these practices could be trained. But stay tuned. Hopefully we'll be back in a couple of years to tell you what we did and how it moved forward.
My Pollyanna gene looks forward to this being part of a culture shift.
Okay. I think Kathy and I will stick around for a few more minutes if anybody has any additional questions. Thank you again for spending your lunch hour with us. Thank you.